And maybe with that brief segue, we can have Dr. Lam Ho, our next speaker, talk about uFR or uFR, depending how you pronounce it. Hype or real? Lam Ho, please.
Thank you. I try to change my topic a little bit. Change it to it's the same thing. The future is TCIP, total combination of imaging and physiology. Why I will have this topic? One is of course for advertisement. We have this meeting in Hong Kong. If you have chance, come to our meetings. The other reason is think about that. In the past, at least 7 major trials, all the chronic ischemic heart disease you do PSI actually is not over, it's not better than medical treatment. Nowadays we have imaging study, imaging guided PSI is better than coronary. And sometimes in left-wing is maybe a little bit better than CABG. So next slide. However, can we do it better? Can we make sure our PSI is better than medical therapy? So probably the future we can try to combine imaging and physiology in the procedure. Maybe that is one of the way to make your procedure better than medical therapy. So we all know that imaging become Class 1A guideline in ESC, ACC. But there's one minor things I would like to highlight is uFR, QFR. In fact, in 2024, it's 1B in ESC guideline. And among the 4 studies to support this 1B recommendation, 3 are from uFR. What is uFR? Is use some AI, and then I found that even I use 7.5 frame is still accurate, and try to correlate with FFR seems is okay. They involve many mathematics, but I'm not the guy who know everything about that. But at least I know that all the studies are very controversial. For example, fever fee in Europe, everything. But at least now it's Class 1B in guideline. And there are some study, and you can use it in as a prognostic value for post-PCI. So I will try to illustrate this, why it's so useful. For example, like this case, the patient had some moderate to severe lesion over the mid-AD and also proximal AD. So immediately you see this angiogram, you will have 2 questions in your mind. One is treat or not treat. How many of you will stand this AD? Who will stand? Or just stand the proximal lesion, or stand the mid-AD lesion, or both? Panel, will you stand? It's difficult to say, right? Yeah. So, and then we try to do the uFR. Now it's the magic. We just use 7.5 frame only, and just one view, no other single pane, just one view.
Do you have uFR? No.
Okay, so just one view, 0.78. So it's positive. Yeah. Then we know that is significant. Is that true? This case we have not repeat FFR, but we use another view. You can see that the proximal AD lesion actually is very tight, very significant. So just forgive me, by IFR, I guess it's very compatible with the uFR finding. Yeah. We don't repeat because you need to pay money for FFR. Yeah, and then so it's not just to decide whether it's significant or not. You can see with all this AI calculation, everything they can tell you, if you stand the proximal lesion, you just need 18 mm stand, and the delta in uFR is 0.11. And if you stand another 27 mm over here, the delta uFR is 0.09. So AD lesion is more significant than the mid-AD lesion, and it's very compatible with the angiogram. Also, to the second question, can we just stand the proximal, or can we just stand the mid-AD? You can tell if you stand the proximal AD, the residual uFR is 0.89. So it's not very good. It's because from this trial, we know that if the uFR is less than or equal to 0.89, the MACE fee in the future is 3 times higher. So for this case, we are very confident that we have to stand both mid-AD lesion and distal AD lesion. However, can we skip that? In this part, it seems very normal. Where is the good landing? The landing after many years, we know that the landing is more important than the length of the stand. So can we spare this area? In fact, uFR cannot tell you, physiology cannot tell you, only the imaging can tell you. So you can see we do the OCT in this area. We found that, in fact, the middle part is lipid rich and there are microchannel, there are neovascularization in the lipid rich part in the mid-AD. So it's not a landing zone. You have to stent both area. So we pedilate and then stent. This was the final angiogram because some lipid rich part, there's a little bit no refold. We give some adenosine. And this was the PPCI. This was the final angiogram after 2 stents. You can immediately feel that the fold is significantly improved. So, and then we repeat the uFR. Now it's 0.98. This is a 3D version, but I can tell you in our experience, also in Australia's experience, they found that 2D is more accurate than 3D. You found a good 2D view is better than use 3D. So another case to illustrate, the uFR is 0.29, so of course significant, and then we do stand and then do the uFR is, can we pay the OCT? Yeah. So definitely uFR was 0.82 only. And from the, now we have AI program, it's Ultron 2. If it's under expansion, it will tell you it's orange in color. So you can see, this one is easy. You can easily see the OCT image. You know that it's under expansion. You need to do something more. Okay, next slide. So we do high pressure ballooning after 18 ATM. So now you can see the OCT image. What do you think? Is it really under expansion or anything happen? Now, this is why we need AI, I should not think AI, but machine intelligence to help us. From angiogram, if without the AI, without the Ultron 2, without all these things, just by my eyes, I will say it's good expansion from the OCT. Yeah. It's good, relatively good, just minimal. But from the AI, you see lots of orange color. So from the machine intelligence to tell you, the expansion is not good. We all use AI nowadays. You use Google, you have AI mode or whatever. But it's difficult to fact check the AI, whether this AI recommendation is correct or not. It's really difficult. But from your human eye, it seems okay. So we use uFR to check. Of course, if you have core lab, maybe some expert can help you, but I can tell you most of us are just normal cardiology, normal interventionalists. We are not those super expert in imaging. We may not be able to help. And then in this case, I just checked uFR. This patient's uFR was 0.88. So it's still not very good, very satisfactory. Then I know that we have to do something more. And I do the high pressure ballooning, further optimizes. Then you can see that the orange color disappear a lot. Here maybe just some artifact. You can see. But now just be honest to yourself. You just see this OCT image and compare to the previous OCT image you see by your human eye. It's really difficult to find significant or non-significant expansion. So, and then we check the uFR again, this time 0.95. So now it's good. We know that we had optimized, we had done good enough. So probably that may be a way. We use uFR as in PPCI to decide whether you stand or not, or stand where. And then we use imaging to optimize all the landing, size, length, everything. And nowadays we can also include the machine intelligence to help us to assess expansion, everything, and then use post PCI uFR as a final gatekeeper. Because physiology is always better than just anatomical assessment like the MLA for your vessel. It's more reasonable to assess whether it's significant or not. That's the end of my presentation. Thank you.
Thank you, Lampo. Really good talk. Just so that the audience know what uFR is, this is technology that is it still with Micropod? Or which
I don't
company is
know
it?
which company, but anyway, we had tried some. I forget about the name of the company.
If I remember correctly, and I hope, is there anybody who knows exactly, is Micropod, right? If I remember correctly. I think they were distributing, depending on which company they distribute, is software embedded on floral machines on your, so they can analyze for you on the spot. So it's almost instantaneous, if I remember correctly.
Yeah.
But it is one of many of these angiography-based physiologic technologies. And what I think Lamho has very nicely illustrated is how it is used in practice. So really there's a lot happening, and I think as a collective community, we probably have to find the right integration to our workflow, because none of these come cheap. I mean, whether it's OCT or uFR or whatever R, they all cost money. So we'll have to have more discussion on this. Maybe with that, we'll move on to the next talk, and then we'll discuss more at the end if time permits.